cominciare, sono le 10:35. Cominciamo questa seconda giornata sull'Aging Wealth. Il mio nome è Massimo Dominici, sono ricercatore dell'Università di Modena, sono un medico, sono un ematologo, un oncologo e mi occupo di attività di ricerca relative all'utilizzo di cellule staminali. Abbiamo programmi che riguardano anche l'invecchiamento. Io penso che il convegno sia in inglese, per cui in questo momento cambiamo lingua. So good morning everybody, my name is Massimo Dominici. I'm going to be the moderator for this morning and this afternoon session. And when they invited me to speak about aging, I was looking about words which can communicate the importance of having the aging as a focus of this meeting. And one of the words that came up in my mind was the independence. Being independent for elderly is one of the major aspects for wealthy aging. And being independent is something which is sometimes a simple word, apparently very easy to achieve when you are young, but when you're getting old, these things, you need to have someone which is taking care of you. So technology, social services and system may work together to create and to improve the independence of elderly. And so this is why it's important to dissect each of the single aspects which are related to the independence. And so we have an honor to moderate this session. So we're going to go through the several pathologies which are related to being independent. And we were going to decline these topics into the prevention. Okay, prevention is very important, we know. And so I have the pleasure to introduce the first speaker of this morning. He's coming from the University of Montpellier, in the University Hospital of Montpellier. Is Professor Davide Caimmi. He's going to talk with us about the Airways ICP. So please welcome to the podium.
Let me introduce myself. Davide Caimmi, I work in Montpellier, France. I work with Gian. I don't know if any of you know him. He's really into this topic that I'm going to talk about today. And what am I going to talk about? Well, Airways ICPs. I have no idea if you all know what ICPs is. I basically recently discovered it. But you need to know what it is. So let's find out together. What I'm going to talk about, Airways ICP. Airways, I'm going to talk to you about what chronic respiratory diseases are and why we really need to focus on that. Each one of us surely is interested on his own work, but I'm going to try to convince you to see what we are going to do and what we're going to plan to do. Non-communicable diseases include airways diseases, chronic diseases, and we all know how to treat them in kids. Just a small parenthesis, I'm a pediatrician, so I'm really into kids. But what am I doing here? I will explain to you. When we talk about respiratory diseases, we're talking mainly in elderly about asthma, cough, and allergic diseases in general, which they show a prevalence which is pretty high. You see, as for asthma, we have more than 300 million people. And non-communicable diseases in general, they all have like the same risk factors in common. CVDs, these are cardiovascular diseases, and CRDs. You see, most of it, tobacco smoke, it's one of the most important. Physical inactivity and pollution, air pollution. And in general, non-communicable diseases have something else in common, which is very important in chronic respiratory disease as well. As you can see, pain is a painful condition, and patients are depressed and are full of anxiety. So when we think about all the non-communicable diseases and chronic respiratory disease, we have a common pattern. And the European Innovation Partnership on active and healthy aging is helping us, of course, and supporting this topic as well. We have Airways ICP, and we can take the same model that we did also for the data also for cardiovascular diseases and type 2 diabetes. And what we are going to do is actually, well, first of all, we are reference sites. I don't know if any of you have ever been in the region, like Lodz Museum, just in case you come visit us. It's a lovely region. And Montpellier is a lovely town, so just to let you know. And as a reference site, we are trying to do our best to promote this program. The risk factors, we all know that. Several risk factors, they are going to lead to what? They're going to lead to an impaired aging. That's not what we want. We all know very well tobacco smoke is one major environmental risk factor. But there are other risk factors that have to be considered. So basically, the plan is to work on prevention and control of the disease, of the chronic disease. But we also want to prevent its onset and all the consequences. So why don't we start early in childhood, working to prevent what's going to happen later on during life? So Airways ICPs, we actually published the paper in August this year, explaining you, yeah, you see there are many authors. I see your face. And it's been launched by the NHS in England, UK, sorry, by Matteo recently in February as well. And we have several things to do. So we're not just going to go through the whole thing there. I just want to focus on a few of them. First of it, we already know guidelines exist. We're not going to change the world like that. But what we want to do is to think about what single country in Europe has done. So we see, for example, in Finland, that fight asthma can be successful. What did they do? Well, they have a zero tolerance policy on asthma deaths. What that means that they basically have lowered so much asthma death, asthma-related deaths. So in another country, what they said is like, guess what? In '87, they predicted that the cost for asthma was like 250 or 500 million euros more than it actually is. So we're doing a pretty good job probably. And in Brazil, they lowered the number of hospitalization. So several programs already exist all over the world. In Italy, these programs basically, not for asthma, for cough, to reduce the use of tobacco and smoking. And in Portugal as well. So every single country, every nation has developed some kind of preventive program. We want to put all of this together and using the WHO approach, we want to have a common approach for the control of the severity of the respiratory disease. So we know pretty much how to get closer to a patient who has asthma, severe asthma. That's something that's been also uniformed by the World Health Organization very recently. And once we have known how to do with asthma, we want to enlarge the whole thing on allergic respiratory diseases and cough. So why? Because most of it is kind of confusing. I just will focus on the important thing. Basically, when we do not diagnose asthma, when we do not treat properly, when we do not take care of what the patient does at home, and we don't really explain to him how to deal with this disease, we are putting the patient at risk. So we are going to plan, we already started with that, some meetings to ask to a panel of experts how to deal with these conditions. So for example, when we face someone with asthma or cough, what are the questions we have to ask ourselves? So our prioritized questions were on asthma, cough, rhinitis in older people, and comorbidities. And also we vetted pediatric interventions to reduce this comorbidity. So this is just some questions on asthma comorbidities and cough comorbidities. And then we have the ICPs. Okay, what do? We know allergic diseases and asthma often start before the age of 18, pediatric age. We need to focus on prevention, early diagnosis, 2 major points. And we said, well, let's use the ARIA approach. I think most of you are not familiar with ARIA, which is a guidelines on allergic rhinitis and asthma. And it's been redone by the great system. It's a pretty good guidelines, let me tell you that. It's been published in several languages. And in the 2010 revision, we have plenty of papers that talk about ARIA. And it's been several analyses have been done for this kind of guideline. And in a paper in 2013, seems like, as you can see there, ARIA is pretty much the best one. As for scope and purposes, clarity of presentation, and applicability. So, we need to use this system to create ICPs. And what do? ICP are not guidelines. ICP are made by a multidisciplinary teams. They're not just allergists, they're not just respiratory experts. And basically are guidelines that are put into the real world. We want to see what happens when you do it in real world. How you change your attitude toward each single patient. And every alteration has to be included in the ICP. So the same thing, we're going to do it with ARIA. And every variation has to be included. And the 2 major things is that, well, that's what comes up from ARIA. If you have rhinitis, look for asthma. The same thing. If you have asthma, look for rhinitis. But how do we control these single patients? You know, I don't know if you know, there are like systems that tells you, you know, this week you're going to have a lot of rats coming out and you're going to sneeze. Well, that's kind of cool to do. But we have to have a real sentinel that it's developed by the patient themselves. That's what we thought about. How do we do? Well, each patient just gives us a text to our system that tells us, you know, today I'm sneezing. I'm allergic to grass, and today I'm sneezing more than usual. Well, that works much better than counting the pollens in the air, because it's the real symptom presented by the patient. And once we do that, we can alert the other patient who have the same symptom. You know, in your area, the allergen is going to be higher this week. So basically, it's one of the many approach to applications for cell phones. And it all based on the visual analysis scale. So the base says how much is bothered by the allergies. The same thing we can do then with COT, with a list of prioritized questions for people, for elder people. And what are the questions we can ask to these people? First of all, I don't really know how many of you are doctors, and also I told you I'm a physician, so I don't really understand that. But I don't never really understand I don't see a huge difference between cough and asthma in old people. I see when I just really talk to them, but when I really see the patient and he talks to me about his symptoms, I don't know, do you really see a difference? It's kind of difficult. You have to go really deep. And how deep? And what kind of question you have to ask? And about all the drugs that people take, especially elderly. And then once we've done all of this, we have to just spread out the word. How do you do that? I told you about Matteo in February, and it's a list of things to do. Like MOH in Rome was like on Tuesday and Wednesday. The EIP for the reference site of Montpellier will be on Monday and Tuesday next week. And we're just going up. And we have plenty of meetings to just see people and see what people can do and what we think we could do to just like move on and just not be stuck just with the rhinitis, which is like what I'm going to be focusing on. So I really like that project, but to enlarge the whole project. And well, that's what we had this week in Rome. And then the whole goal is like to just do what the WHO told us to do. So there are targets for 2025 and an action plan with 6 different objectives. And so we have for non-communicable diseases, we have to increase the prevention and control of symptoms. At the same time, we have to focus on national capacity, leadership, governance, to give a response to this kind of questions to prevent and control non-communicable diseases. We have to eliminate, possibly, modifiable risk factors. Well, of course, tobacco is the first one. And we have to push, let's say that, healthcare system to do the best to prevent and control non-communicable diseases. And for a universal health coverage, we have to support national capacity of high-quality research and to monitor the trends and determinants of SPDs and evaluate the progress we're doing. So, globally talking, ICPs, it's a real translation of guidelines in clinical practice. It's focused on the patients. It's not focused on the MDs or any other member of the team. It's a multidisciplinary approach to the patient. And it's a really, it puts the subjective into the standard. So the patient in front, the doctor in front of the patient, that's the subjective part. That's where we try to follow the guidelines and try to put the patient in the right place, and we change the guidelines following what the patient needs. So the project will achieve the objective of an active aging and for the early diagnosis and treatment of chronic diseases as early as possible. That's why I'm into the project as well. And healthy, to improve healthy life years and reduce burden, while at the same time improve quality of life worldwide and to reduce the disease incidence. So basically that's the project that we are trying to do on airways, on respiratory diseases, and that's what we hope we're going to achieve by 2020. Thank you.
Thank you very much for the presentation. I think we're gonna move the questions round table. If there's any burning question for Dr. Caimmi, we can take one single. Otherwise, we're gonna use the round table to discuss the presentation. Okay, thank you very much. So it's time for the second speaker for this morning is prevention in cardiovascular disease. Is Dr. Kostka from the University of Lodz. So please welcome. And cardiovascular diseases, is a prominent cause of death. So prevention in this case is very important, and it's going to interest the majority of people in the Western world.
Thank you very much for the invitation. I'm really proud proud and honored to be here. I'm going to talk about prevention of cardiovascular diseases. I represent here also my Medical University of Lodz. It's just in the middle of Poland. And Healthy Aging Research Center, which is the RECPOT European Union project currently run at our university. So first of all, I will focus shortly on epidemiology of cardiovascular diseases, then I will talk about prevention of cardiovascular diseases in general population, and then I will focus on particularities of prevention of cardiovascular diseases in older people. Here we can see population pyramid of Poland. In just 30 years, this population pyramid is going to change dramatically. During the last 25 years after socio-economic transition, average lifespan in Poland increased more than 6 years, both in men and in women. So we face really very important challenge of aging society in all Central European countries. Cardiovascular diseases are the main cause of mortality in the European Union. Coronary heart disease, stroke, and other cardiovascular diseases constitute almost half of mortality in European countries, both in men, even more in women. So it is still the most important health problem. How can we prevent cardiovascular disease? What are the main guidelines to prevent the spread of cardiovascular disease? We concentrate on risk factors of cardiovascular diseases, which are shown here. The main risk factors are diet, smoking, family history, lipids, glucose, blood pressure, anthropometric data, body mass index, waist-to-hip ratio, and other laboratory measurements. These are the main cardiovascular risk factors that should be considered in prevention of cardiovascular diseases. The majority of them also is important in other chronic diseases. This is the score system which assesses the risk of cardiovascular diseases. This risk is different in men and women, increases with age, is higher in smokers, increases with higher cholesterol level and higher blood pressure level. This score system is now divided into two regions: high risk countries in Europe. These are mainly Central European countries, and low risk regions of Europe, Southern and Western Europe. Current guidelines on prevention of cardiovascular diseases were launched during European Society of Cardiology Congress in 2012 in Munich in Germany. And those guidelines tackle the most important measure we should undertake to prevent cardiovascular diseases. Those measures include behavioral changes, lifestyle, smoking prevention and smoking cessation. Guidelines regarding nutrition are very well known. They are based on Mediterranean diet, so I'll just show them very shortly. Guidelines regarding body weight. Here I will stop just for a minute, because in general population we can see that all-cause mortality is lower with the body mass index between 20 and 25. I will point to this suggestion later on, whether is it true in other population. Physical activity, all people should engage in regular physical activity. 3 to 5 hours per week, depending on the intensity of this physical activity. Management of psychosocial factors, how should we couple with the stress? And major new key messages concerning the most important risk factors are that we should target blood pressure to be lower than 140 and 90 systolic and diastolic blood pressure. Diabetes mellitus and glucose level should be taken under control. So-called glycated hemoglobin should be below 7%, and blood lipids, especially so-called bad LDL cholesterol, should be low, especially in high-risk patients. In secondary prevention, we use antithrombotic therapy with different drugs. And now I will move to the prevention of cardiovascular diseases in the elderly. Is it the same or is it a bit different? Here we've got the data as an example of one of our recent studies in Polish population. We can see that ischemic heart disease, the prevalence is more than 30%, independent of the living condition in urban, rural, or institution environment. Hypertension, about 60% of all the people are hypertensive, not only in Poland, in Italy, in France too. Chronic heart failure, especially high prevalence in nursing homes. More than 10% are post-MI after myocardial infarction patients. About 10% on the average are post-stroke patients. The prevalence of diabetes is about 20% in all the population. So cardiovascular or cardiometabolic disease is usually present in our older patients we deal with. Current cardiovascular disease risk profile assessment tools consider more than 10-year risk in young or middle-aged subjects, and this middle-aged risk usually evolves to a high risk in an older individual when we use current measures. Furthermore, currently available risk prediction tools are valid up to a certain age, usually to 65 or sometimes a little bit more. So the most important risk estimation tools like Cunningham score or the most important score system are usually valid till the age of usually 65, sometimes a little bit more. And given we have many millions of people in Europe that are 80 or 90, this system doesn't work. Here is an example of one of the most important studies published during the recent year, Inter-HARC study, when we can see the differences of odds ratio of the risk of myocardial infarction in patients older and younger than 60 years. We can see differences in almost every risk factor. The most important are that hypertension, smoking, dyslipidemia, and diabetes remain significant risk factors for myocardial infarction in the people aged more than 60 years old. Conversely, especially in men aged 60 years or more, moderate alcohol consumption and physical activity become more important protective factors. What is especially concerning alcohol consumption, good news anyway. Several recent studies show a significant improvement in discrimination of risk estimation when we use specific biomarkers, including interleukins, C-reactive protein, troponin, brain-attenuated peptides, cystatin, or carotid plaque burden. So when we use these new substances to discriminate risk in older people, like homocysteine, folic acid, or C-reactive protein, we can discriminate the risk better than in the younger population. Those new indices of potential new indices of cardiovascular risk are not included really in the guidelines, but the European Society of Cardiology states that the use of some of them may be considered, and they may be used as an additional risk factor assessment tools. Especially C-reactive protein, it's an interesting example because it is a marker of inflammation in our body. And C-reactive protein increases during inflammatory diseases, which are very common in older age. And only recently, there are few studies that started to deal with the relationship between cardiovascular diseases, inflammatory markers, and real geriatric syndromes like Freites syndrome, sarcopenia. Those syndromes that are related closely with disability, which is probably the most important target in all the population. Not the diseases themselves, but disability. We can function pretty well with several diseases when we are capable to do basic activities of daily living. And those factors, inflammatory measures like C-reactive protein or interleukins, are new markers, and conventional risk scores perform unsatisfactorily in older people. We should consider use those new markers. Here there's an example, one of study of our center when we have compared the sign of subclinical atherosclerosis to the physical activity in real life. And we can see that physical activity when we are younger or middle age has very strong relationship with our atherosclerosis status when we are older. Coronary artery calcification, carotid intima media thickness is lower, and the reactivity of the vessel is better when we were physically active in our middle ages. So the accuracy of risk estimation has been generally shown to be substantially lower in older persons than in middle-aged people. And better risk estimation in older people will only be partially solved if we use cardiovascular disease prevention tools. Other aspects should be considered, like what level to consider as high risk, because when we use, for example, the SCORE, the most known rating system, and almost all people who are older will have a very high risk, and should 10%, which is considered as high risk, should be considered also high risk in older people. There are several studies which have shown that we can influence risk factor even in older population. Here is a very known HIDET study published a couple of years ago in people aged 80 years and more, when lowering blood pressure had a beneficial impact on overall and cardiovascular mortality. The same with lowering cholesterol level in older population. We have now data indicating that yes, we should consider lowering LDL cholesterol even in very old people. But although the recent randomized controlled trials of preventive measures in older and in very old people have demonstrated that significant benefit can be achieved, it is still uncertain whether risk stratification can assist in targeting this measure towards those who will benefit most, and if so, what threshold is appropriate in this age group. And whether we should concentrate on disease-specific or overall health approach. Evidence-based approaches work in discrete conditions, not in individuals with multiple disease. And treating the disease might not be always good for the patient with multiple conditions. I was very glad to hear yesterday that we are moving from paying per service to more holistic approach. For example, general overweight and general abdominal obesity are independently associated with an increased risk of heart failure. It is very well known. More obesity, more heart failure. But more obesity in real life, because there are now several studies that have shown that in really older population, the best survival is with body mass index between 28 and 30. There are several studies that have shown that mortality was lowest for overweight patients in older population. So overweight should not be a problem when we get older. In very elderly subjects, even with diabetes mellitus, increased body mass index was associated with reduced mortality risk. So single disease model should not be applied to preventive measure in older people. And we should identify factors which may affect quality or quantity of life in this population. In geriatric population, we cannot discern between risk factor and diseases, between prevention and treatment. We treat hypertension, we prevent heart failure at the same time. So, the main conclusion from my short speech are as follows. When we talk about prevention of cardiovascular disease in the elderly, we should keep in mind that usually cardiovascular disease is already there. Several cardiovascular disease risk factors are usually existing or coexisting. Prevention should be integrated with treatment, and overall health approach is needed. We should not combat single diseases. We know very well from several studies, for example in diabetes, that lowering too much blood glucose level had led to increase in mortality. Why? Because too low glucose level made all the people to fall more frequently and increase mortality. Thank you for that.
Thank you very much for the presentation outlining the importance of simple things which we can do in our daily life to prevent diseases. So in this case, we're going to discuss this round table. So thank you very much. So it's now time for Dr. Giancarlo Garuti. He's going to speak with the project SmartCare and Regional Strategy for Integrated Cares. Coming from Trieste, from them.
Thank you. Good morning, everybody. Thank you for inviting me. I think this is a very good opportunity to discuss on topics we are facing commonly and to meet also friends and colleagues. I'm currently working as project manager of EU-funded projects for the Friuli-Venezia Giulia region. I am a project manager and I am an urban sociologist. Sorry for that. And so I'm not going to present very technical and clinical aspects as the previous speakers, but I'm going to present more a process of integrated care. And I come from the Friuli-Venezia Giulia region, that is one of the oldest regions in Europe. The percentage of over 65 is around 25%, and in city like Trieste, where I live, is already 28% the percentage. So the region has set up already a system for integrated care. And what I would like to present in this process is that we have a good tradition of integrated care, but so far is not supported by ICT. That's why we have a lot of initiatives, experience, and I'm going to show you also some projects that anticipated SmartCare, but no ICT supported. So as you can see, we have this integrated care model based on regional initiatives and also national initiatives. So the region has just approved a big health reform, a reform health system 2 weeks ago. So it is going also to strengthen this kind of approach for integrated care. The community-based care, home care, and the chronic disease as the main topic of the social health care, less than the acute event and the hospitalization. And of course, the last point at the bottom of this slide is that integrated care is not just social and health care, but it is to integrate with the innovation policies and housing policies. About pilots and experimentation that we had so far, so we try to put technology and ICT innovation in this tradition, this health and social care. So we have some regional initiatives, that is the ones you can see in the slide. We have a regional innovation law with a specific article on welfare, innovation in the welfare, that funded several projects on domotics, automation, accessibility. And we have a strategic project about accessibility, home care, innovation. And we have now a regional cluster on technology for ambient of life that is based on the national cluster that has the same topic. And also at the international level, European level, we have tried to put some funds, of course, and also some pilot experimentation to strengthen this process. So we are in the European Innovation Partnership for Active Aging, in the G4 group about age-friendly cities. And we had other cooperation territorial projects like HELPS in the Central Europe program and CASA, funded by Interreg 4C program, and a previous ICT project that was dreaming, that was specifically telemedicine and not integrated care, not so much as SmartCare. So the challenge that we have, and I think that some of the speakers yesterday already mentioned it, is to pass from pilots to policies, from pilot to practices. And of course, this is what we are trying to do in our region also through the SmartCare Project. So the SmartCare Project is to pass from usual care to integrated care supported by ICT. As you can see, of course, there are health care and social care that have to be integrated better than as they are, and also the empowerment of citizens, of patients, and of informal carers as well, with the self-management and self-help practices. We are involving in the project 24 regions and other many institutions like users, organization and users representatives. And just to go, because then I will repeat some of the things that you had in this slide. Okay, this is the formal slide of SmartCare that I had to put in the presentation. Of course, it is a 3 years program, ICT PSP, pilot up, with support policy program. So this is the main objective. It's not just to experiment ICT, but to strengthen and support policy implementation. So, SmartCare is not an ICT project, it's an integrated care process enabled by ICT. We are running 9 deployment sites. I'm not going to present the result, just some lessons learned so far at the end of the presentation, because now in these days, in these weeks, the deployment site is starting the concrete deployment. So we had a lot of work, of course, about methodology, about operational protocol, and about the operational plan to start the deployment. And these weeks we had 2 regions that already started. It is Aragon in Spain and South Denmark. And Scotland and Friuli-Venezia Giulia is starting these days, and there are other 5 regions starting now. Of course, the aim is also to clarify potential models for integrated care. So this is, of course, one of the goals to support the policies. I think that we had already seen this slide yesterday, presented by Bridget. So it is just a picture of what I'm trying to present you. So I would like to go to the next ones because I don't want to run over time. And the main point is that ICT is not the goal. ICT is an instrument, a tool to enable integrated service. So the point is to have organizational model, subsequent action, supported by ICT where reasonable. Not always, but where reasonable. And of course, the integration needs the involvement of end users. So we put a lot of attention on this aspect, involving, as I already said, and users board and also the end users. So the requirement of end users, all the people, informal care, professionals, and and representative of user support. So this is the picture, the global picture of what we are trying to do in the program. So of course we have a manager structure, we have a user advisory board, we have committed regions. So as you can see, we have 9 pilot regions, 9 deployment sites, and we have other committed regions. We are trying to be involved, to keep some lessons learned, and to try to develop in the region what is developed in the SmartCare project. Of course, the program is not just pilot service specification, but building blocks of all the action needed from ICT to organizational model for the integrated care. And of course, we will have the final evaluation of the work we will implement. So what we are expecting is shared outputs in the partnership. Of course, integrated care pathways validated in service model and a value chain. So this will be the main aspect of the validation of these integrated care pathways. Of course, a common ICT integration infrastructure architecture. This is one of the points that maybe is more challenging, because when you have a lot of pilots in a region, in a territory, you risk to have also a fragmentation of technology. This is one of the points that, for example, we have in our region. As you can see, we had several projects implemented in the previous years, and we have different technologies in different pilots. So the point is also to have this integrated common ICT integration infrastructure. Of course, operational guidance, as the previous speaker said, there are a lot of guidelines. What we are trying to do is to support the region with the operational plan to start deployment of integrated care. Of course, a focus on sustainable business, a cost efficiency study will be implemented during the deployment sites, and also a consensus building, how the change management can support the regions, the territory on integrated care to find a consensus. And the last one is the contribution to European Innovation Partnership, or either B3 Group on integrated care and the European Commission in asking SmartCare to have this focus to support the European policies. So what we are expecting from ICT, as I've said, is not an ICT project, but ICT is really important. And the role of ICT is to support the care coordination, of course. There are silos that is often divided, so to go beyond silos through the ICT. The information sharing, of course, the integrated and multidimensional and joint assessment, also through the ICT support, and also, of course, the empowerment of citizens and patients and care recipients with the technology for self-care and self-management. So it's not so clear maybe, but this also yesterday was already presented, but this is the, we will have two pathways for the experimentation. One is the long-term pathways, and one is the post-discharge pathway. This is the long-term pathways. Of course, we have entry points, and in this case it is divided, the entry points, because it could be a social care entry points or healthcare entry points. For example, in Friuli-Venezia we have a unique entry point because we have already an integrated assessment of social and care needs in the local health districts in the territory. So there is an assessment for the enrollment in SmartCare, and then when a citizen, a patient is enrolled, of course, there is this multidimensional assessment for the health and social care plan. Then there is a personalized provision of care that is in the center of this slide, and then, of course, all the evaluation and living point. This is the hospital discharge support that is more or less the same. Of course, the entry point is different because it's in the hospital where we are trying to set up an integrated care assessment for after discharge for the continuity of care. This is some figures and numbers that are foreseen in the different deployment sites. As you can see, there are different regions, and we have Attica in Greece, South Karelia in Finland, North Brabant in the Netherlands, Uppsala, they are 10, but Uppsala has withdrawn, now they are 9, and Kraljevo in Serbia, so we can also compare the system in a pre-accession country like Serbia. If I have just 1 minute and a half more, I would like to present what we are doing in Friuli-Venezia Giulia. So this is our deployment sites about integrated care models, focus on primary care and more focus on cardiovascular disease. We will have 200 patients enrolled. We have finished by now the testing phase, and as you maybe the Italian present in this room knows, we are a long-lasting process for all bureaucratic aspects, and of course we are waiting next week the approval, the final approval of the ethical committee, and now we are going to start in the next weeks the concrete deployment. What is really important is that we have already involved in the management team, also in the regional territory, healthcare, social care, and third sectors, and also informal care. So the target population has over 65, cardiovascular disease mainly, but also diabetes mellitus, and also some kind of frailty from a social aspect. So we will have, of course, a randomized study, randomized control. We will have an intervention group and a control group, and the enrolled patient will be divided in these two groups. And this is a scheme, a very simple scheme of what we are going to implement in our region. So there are the control group that will receive the care as usual, nothing more and nothing less, of course, and the intervention group that will receive a continuous monitoring. We will have, of course, an electronic platform, we will have devices at home, and we will have a call center for the managing the alarms and managing the data. So, the last slide, some lessons learned so far. As I said, I can present results, but some lessons learned in this preparation phase I can share with you. Of course, maybe the first one is quite obvious, but it is not obvious sometimes also for the European Commission, maybe, because Europe can seem as one, but there are very differences still in Europe. So differences in government organization, governance, in funding, instrumenting, financing, but also in providing providers' responsibility. It's sometimes also difficult to say what is social care and what is healthcare, because in some countries you have health providers that provide also social care. So this is a huge difference. When you have to think about how to implement integrated care is not just to focus on care issues, ICT issues, but you have to have a vision about that and to have a model based on the vision. But it's also not simply goodwill, because sometimes you have some people very well involved and very well committed that implement personally a very good experiment, but it is not only that. You still need organization, you still need structure, and of course you need leadership in this innovation. Sometimes when you try to change something, you just move from one location to another, the care, just move from hospital to territory, but it's not the case when it's not to just move the location, but it's to reorganize and to redesign the services. As yesterday we have already listened to, there is a big cultural issue. There are barriers, constraints to change, and so of course change management support. It is really, really helpful to support this kind of change. And the last one is what we have learned so far about the difficult process to implement this innovation. That technology is not the issue. Of course, I'm not saying that technology has not some big issues to solve. Yesterday, Bridget presented the interoperability, of course. But when a region tries to change its system, you discover that technology is already there. You have to put in practice technology, pass from technology to practices, to policies. You have a lot of technology that can already help what you are in your vision. For example, we had a 7-month lasting public procurement process for ICT provision. So if you can understand, 7 months process is very huge amount of time that is risking to stop everything. So of course you have to put in the focus the actions, initiatives to face all these problems, and maybe technology we will help you at the end, but it is not the issue. Thank you very much.
Thank you very much, Dr. Apuzzo, for the presentation. So it's time for Dr. Garuti from AUSL Reggio Emilia. He will, from Italy, so he will discuss about the previous experience and needs and expectation from public bodies. So please welcome.
Thank you. I thank the organizing committee for the invitation. I thank the Dr. Usuati for helping on my discussion. My discussion is centered on the telemedicine for the prevention of the complication on chronic diseases. Particularly, before to enter in the topic of presentation, we need to see why chronic disease has a great impact on healthcare utilization. Chronic disease are the most common, costly, and preventable of all health problems in the world. Particularly, there are many reasons for focusing on the management of these diseases. Because these diseases are highly prevalent, are predicted to increase substantially in the next future, are costly, and they are potentially manageable via telemedicine. There are many studies on the impact of chronic disease in the healthcare resource utilization. In USA, 50% of adults have one chronic illness, and the 70% of all health care expenditure are spent on chronic diseases. There are a combination of factors for treating this problem. because there is a demographic composition of population, and this combination is changing. There are advances in medical science, there are advances in ICT, and there is a fragmentation of care and healthcare research and utilizations. A system that could promise to involve patients in their care, provides continuous monitoring, and identify early symptoms and respond promptly to exacerbation should be considered and assessed. Telemedicine enter in this system because telemedicine can support patients in self-management, provides continuous monitoring by healthcare providers, and could identify early symptoms of exacerbations. Tertiary prevention is the prevention of the damage caused by chronic disease. Particularly, tertiary prevention is centered on exacerbation and is centered on the rehabilitation of chronic diseases. I am a pneumologist and I take care patients with chronic disease, particularly COPD, chronic obstructive pulmonary diseases, and chronic respiratory failure. COPD is a common disease in this century. Particularly, COPD is one of major cause of disability and death in the world. It is estimated to affect about 10% of the population. COPD is the primary contributor to mortality caused by chronic lower respiratory tract diseases. And there are many studies on the analysis of cost of COPD. In this study of mirabilities appeared on chest in 2002, mirabilities and co-workers analyzed the cost of COPD. The cost of COPD is divided in two groups. One for the management daily of COPD, and one of the management of exacerbation of COPD. We can observe that the major cost of healthcare research utilization is due to acute respiratory failure and due to hospitalization of COPD exacerbations. In one study appeared in 2004, the I study, an Italian study, this study analyzed the cost of hospitalization caused by COPD exacerbation. The single cost of one hospitalization is about 3,000 euros. Telemedicine could be entered in this system because telemedicine has two important activities for COPD. First, the monitoring of lung function of the patients. Second, the consultation between primary care providers, example, general practitioner, and pulmonary specialists. In this study, performed by Vitacca and Maugeri Foundation, the researchers found that a telemonitoring of patients affected by chronic respiratory failure could reduce hospitalization, wouldn't call to general practitioner, and reduce acute exacerbation. If in the group of patients we divide COPD patients, we can observe that COPD patients seem to have a greater advantage from teleassistance. This similar study, performed in 2012, is observed that COPD patients telemonitored could be treated at home, and the admission to hospital are reduced. But are reduced the costs of hospitalization respect the control group. Another feature of this of telemedicine on the management of COPD is the prediction of exacerbation. In this recent study, appears in 2014, we can observe that a system of telemonitoring at home associated on the monitoring of health status of this patient could predict COPD exacerbation early with a margin about of 5 days. Telemonitoring and telerehabilitation are a great combination for treatment of COPD and chronic respiratory failure. This study observed that the system of telemedicine associated to remote observation of pulmonary rehabilitation program could improve quality of life of COPD patients and reduce days of hospitalization for COPD. Another big chapter in chronic respiratory failure is the chapter of neuromuscular diseases. Neuromuscular diseases are varying diseases, and chronic respiratory failure and acute respiratory failure are very dramatic events. In particularly, two diseases, Duchenne dystrophy and muscular dystrophy and amyotrophic lateral sclerosis, have a big impact on healthcare results utilization. In this study, appeared in 2010, we can observe that the telemedicine performed on the ARS patients in non-invasive ventilation could decrease healthcare utilization, particularly decrease emergency room visit and hospital admission. The chapter of pulmonary rehabilitation at home is great, is wide, and this study performed by Vitacca and Maugeri Foundation showed that a system combined with telemedicine and pulmonary rehabilitation on demand in patient with amyotrophic lateral sclerosis could reduce healthcare results utilization and the hospital admissions. But not only. Telemedicine feel the patient better, because in the study of the same system of Ithaca, the patients were extremely satisfied with the nursing assistance, and the program was considered to very good by the patients. In our experience, we perform a telemedicine system in neuromuscular disease, particularly Duchenne muscular dystrophy. In 2010, a joint venture with Santa Marianova Hospital of Reggio Emilia, San Sebastiano Hospital and Local Health Trust of Reggio Emilia, and Italian Union Against Muscular Dystrophy, built a telesystem for patients affected by neuromuscular disease. This system consists in monitoring the oxygen saturation of the patient, and in a questionnaire with quality of life of the patient and health status. These data are sent to a center, a telecard provider, and this telecard provider insert the data in a risk chart, and the risk chart is built in 3 zones: green zone, yellow zone, and red zone. Green zone means that the patient, the health status of the patient is good. The yellow zone, the health status of the patient is near exacerbation. Red zone, the health status of the patient is exacerbated. The data are sent to hospital specialists, and the specialist, when the patient is in yellow zone, calls the general practitioner of the patient and the respiratory therapist. Medical and physical intervention are performed. Physical intervention consists in the use of mechanical cough machine, and if the patient is in the red zone, we have 2 ways. One, the direct hospitalization if it is preventable, or the visit at home by the hospital specialist or in the hospital. This system is not built for the emergency. The emergency is treated by the local emergency system. Our data were published in 2013, and we showed that in 2 years had a decrease of hospital admission and emergency room admissions. Particularly, we obtained a reduction of days of hospitalizations and of days of exacerbations. In conclusion, the number of patients with chronic respiratory disease being managed at home is increasing. Home telemonitoring is an innovative approach which facilitates patient management at home, and telemedicine could facilitate information exchange between patient and healthcare provider. For the future, on telemonitoring, telemedicine intervention still need to be adjusted to ensure their suitability to the target population. On telemonitoring, intervention for COPD should be considered the inclusion of easy-to-use technology. The impact of telemonitoring should be explored. I thank for their attention.
So thank you, Dr. Garuti, for the presentation, for sharing this model. We're going to discuss that later on. So it's time for the last speaker for the plenary session here. Ms. Dr. Ilenia Gheno from H. She's going to share with us a talk on independent lifestyles, integrated plenary.
Thank you, everybody, and thanks especially to the Democenter team that for the invite, of course, and for having taken care so well about us in this conference. My name is Ilenia, and I'm here on behalf of HPAC from Europe. And I've been asked to talk about the issues of independent living and aging from the perspective of an older person's organization advocating for the needs and concerns of seniors in Europe. And I've decided to tackle the key issue of prevention from a kind of complementary vision from what we have learned today. And it is indeed through our lessons learned through policies and projects. First, I just wanted to briefly introduce H Platform, which is an umbrella organization gathering 150 members, associations working for older people or of older persons in Europe, in the 28 EU member countries. And our mission is to bring older people's point of view in the European policy debates. And we do that, of course, by consulting with our members and by involving them directly through different task forces. We have 14 task forces, but our experts are called to contribute to the development and the monitoring of policies. And we want to raise awareness of what are the needs and the concerns of older persons, and we want to especially involve them directly and to listen to their voice through the projects, of course, when we try to involve them through advisory boards or through user forum, and also at policy level, where our members and experts are involved in EU campaigns, for instance, on solidarity between generations, on age-friendly environments, and on the re-establishment of the intergroup on aging at the European Parliament. And last but not least, of course, in Brussels we are not working alone. Luckily, we are pooling with other NGOs that are sharing some concerns with us, and especially with the disability movement, with whom we share the motto, nothing for us without us. Okay. And of course, we have been hearing and listening about aging throughout 2 days, two intense days, and the question for me is always the same. Well, who is old? And there is no surprise to the fact that we all are aging since we are born, and it's a real challenge to define what are the needs of an aging population. I like very much this quote from an expert of ours, Angela Cruzet, who was stating that older people are a totally heterogeneous group, and this is a vital point to learn. You have those who continue to decide on their daily living, and those who at the same time have given up. You have those who will grasp the telecontrol and flick to the channels, and those who will leave it in the drawer, preferring to push the button. And I don't know if you recall a Beatles song, When I'm 64. If you just recall the lyrics, I will not sing, I promise, it will be funny to understand how the perspective has really changed on aging. The lyrics present some of the wishes of a person aged 64, according to the Beatles. And if you go through it, you will see how anachronistic, in a sense, it is, how different the perspective nowadays is. And so we are not just dealing with different concerns about a wide aging population, but also of different perspectives in times and space. And I thought that I could focus on prevention from a different perspective here. Tackling prevention from us is also co-create, to involve the users, to empower them, and to do things with them, consulting people. Co-create is also mobilizing, co-create is of course also research. I would like to go through this. Indeed, prevention means also to co-design issues, to involve, as I said, users. The goal is indeed to create services and products that can be accessible, can be mainstream, can be tailored to the needs of this business. But on the other hand side, it's also important that the market produces something that is acceptable by the users. And indeed, through the involvement, we can tackle both challenges. But prevention is also to advocate. Prevention is also to try to break the silence, try to push for a more comprehensive approach on aging. And what we are trying to do at European level is indeed to shape the European agenda towards these issues through the European Year 2012 on active and healthy aging and on solidarity between generations, through the involvement in the European Innovation Partnership on active and healthy aging, and we have learned that some other stakeholders are involved in that, and through the re-establishment of the European Parliament Intergroup on Aging and Solidarity between Generations, for which we have campaigned till the 22, because the intergroups are to be decided next week in October. And this is key for us if we want to move forward and to be effective, especially at European level. Prevention is also to establish age-friendly environments. We have been hearing about environments in several of the presentations before. And with that particular regard, AGE is leading a consortium of a thematic network called AFE InnovNet, which is age-friendly environment innovative solutions. And with the consortium and the network, we work for developing some methodologies that can enable local authorities to assess what is the impact of measures for age-friendly environments, but as well as to allow the sharing of experiences and to go towards the effective implementation of solutions, not just something that stays in the paper and then everybody tends to forget after a few years. The idea would be at the end to launch a covenant on demographic change, and that will be the final outcome of the AFE InnovNet project. And the goal is to be reached by the end of 2015. The project is starting in February this year. Prevention is also, as I said, to mobilize the stakeholders, and this is what we are trying to do through the AFE InnovNet thematic network. There are 29 partners already involved, coming from 16 different member states, encompasses 6 regions and 13 cities, and that of course have the contribution of other partners, not only local and regional authorities, but also research centers, consultancy, communication agency, European network, and we have the strong support of the WHO, because of course we are working for aligning the WHO guidelines for age-friendly cities and to set up European guidelines for age-friendly environments, and we're working also with the Eurofund. But besides that, even before we were submitting the proposal to the Commission, we were able to gather 40 other associated partners that wanted to join. Unfortunately, the consortium had to be closed at a certain step. And it's still possible to contribute and to move on. Indeed, everybody has a role to play, everybody has something to share. Also, bad practices, because we can learn a lot from the mistakes that we have been doing from the past. And it's not just to join the network for the sake of joining, but it's to join the network for being informing, but also to be able to comment and to be able to bring a different perspective and to move forward. We are doing that. We are trying to involve the network and different stakeholders through various channels. One of the most powerful we have experienced is the use of webinars. where we interact directly with the people who are involved and with people who want to have a say or just want to follow up what's happening. And the next one, if you're interested, will happen on the 19th of November, and it will be dealing with the funds available for age-friendly initiatives. And last but not least, prevention is also research. Of course, we cannot neglect research, and we have been discussing about research this morning, and I guess also yesterday. Apologies, I couldn't make it for yesterday. For me, what I thought it was important here to state the work to be presented is the DOREMI project. It is involved in about 20 different European projects in which we are trying to involve older persons at the one hand side, but also to raise awareness of what European research is funding. And with the DOREMI, I think it's relevant for you to know because this project really works on prevention. And it studies the early signs of unhealthy dietary habits, of sedentariness, of cognitive decline, which are the main causes of premature death and diseases. And a group of older participants is taking part in pilot studies in Italy, in the UK, where they are participating and they are introduced to food intake measurements, personalized metabolic control, exergames, and trainings. It is indeed by recording the lifestyle changes that we can then provide early warning signs. And here I brought with me the first newsletter of the project. I brought some copies and some brochures in the poster session you will see. And there we summed up the achievements of the first 6 months of the project. And we will do surely more in the next months because we are planning to start up an online user community. And we would like to test some of the games, also of course on prototype versions, directly online. So if you want to have a taste of the experience once back home, you're more than welcome. And last but not least, prevention is also to make others aware, and so to disseminate. And here I thought it was worthwhile to mention the IVISIO project, because the goal of IVISIO is indeed to enhance the visibility of European research. What we have been doing so far is to analyze the assets and barriers of some ICT-oriented European research. And we would like now to build synergies among them, to cluster them, and to allow them to interact, to overcome solutions, and at the end, to overcome barriers. And at the end, we would like to address to the European Commission what are really recommendations for future research, in order, as I said before, to learn from the mistakes we have done in the past and try to not reinvent the wheel or reiterate the same mistakes. And for that, IVISIO has been dealing with 3 trainings so far, and a couple of them are also up ahead of us. All the material is available on the website, and you will be able to have a look to the trainings on communication, which was the first, on exploitation and validation of results, which was the second, and the last one on the business canvas modeling. Indeed, to move forwards and to try to avoid to stick to the research bubble and try to go beyond and to reach the market. So this is all from my side, and if there are any questions, I'm available afterwards and also during the breaks. Thank you.
Thank you very much for sharing all these projects going on in the nation. So we are a few minutes before the schedule, which is very good. So I'd like to invite all the speakers of the session on the table here. And we're going to have time for round table. And then I would like to invite Lucia Pannese from Imagery and Ilaria Mariani from IMAGIS. I think we have some regret. Francesca Corrado is not here. Okay. And so please welcome Lucia and Ilaria. Maybe we need some more chairs, please. Summarize the morning and all these very interesting talks we have heard, and I think we were talking about prevention, and I think we have touched the major aspect of prevention. You know, there are at least the well-recognized levels of prevention. We have three types of prevention. We have primary prevention, we have secondary, and we have a third level of prevention. And the first two speeches related to lung and cardiovascular, we heard about reduction of risk factors, which is the aim of primary prevention. And we have also heard way to early detection of diseases. And I'm talking specifically about the project which was presented by Dr. Apuzzo. But also we heard about tertiary prevention into the lung system, thanks to the colleague from Reggio Emilia. So all these three aspects together are now ready for your discussion, and any question from the audience would be welcome. And we have also individuals that didn't speak, and we have Lucia Pannese and Ilaria Mariani, and so maybe we can start from them, since you didn't have the opportunity to share your vision in this topic, and so that maybe we're going to have a discussion. So please, would you like to introduce yourself briefly, and then, go ahead.
Thank you. I'm Lucia Pannese. I'm the managing director of a company called Imaginary, based in Milano, and we're specializing in serious games. These are some examples of the games for health that we develop. So we are not exactly into the medical topic, nor into the topic about elderly people, but we work a lot with colleagues like Ilenia, for example. She mentioned the WellB project before. So what we do is using our competence in game design, and I'm talking about games for goals other than entertainment, to prevent diseases, to prevent incidents, to make people, to put them at the center of their health process, health management, so to empower them as we heard before, or to do some things that have to do with rehabilitation and retraining them to have a normal life. So that would be it from my side for now.
Okay, very good. Very good. So any comments on this? I think maybe we'll take this opportunity to address all this technology embedded in the prevention fields. So I'd like to hear from Ilaria Mariani, who's next to me. Introduce yourself.
I'm Ilaria Mariani. I'm finishing my PhD, and I deal with games for change. I know my topic is quite far from the other, because I don't necessarily deal with telemedicine, but with a more direct contact with people. So games to help increasing in general awareness in people and create a critical reflection about sensitive issues. In my research group, we develop different kinds of games, from urban to board game, or also digital games. And our aim in general is to create, to engage people in a fun way, to engage them in something difficult to speak about, and use this opportunity, the games, as an opportunity to have a critical debate on difficult topics, generally. Thank you.
Okay, thank you very much. Now it's time for you from the audience to have questions for the speakers. There's a question just right there. We'll be there. 1 second.
I wanted to ask a question about motivation and participation, because in all of this telemonitoring, I think it's interesting to work out, particularly for long-term conditions, how to maintain the user of the system, the patient, in recording the data. And I just wondered what your experiences were. One, in terms of the pilots that are going on, to what extent do you have dropout, and to what extent do you put effort that goes beyond the normal protocol in order to keep people in the study? Because I think these are interesting measures in terms of the either motivational deficit that there might be in terms of getting these things to work. And I guess Lucia may very well want to say something about motivation in terms of gamification as well. So that was my question.
If I'm able to switch this on. Yes? Okay, because it's not blinking. Anyway, so yeah, sure. About motivation. First of all, let's say that it's very early stages. So we cannot tell you about experiences of games that have been used for, I don't know, a couple of years, where we can really statistically also observe dropout rates or whatever. So this is the first statement. Sorry, so just maybe for the translation, I was saying that it's very early stages, so we don't have games that have been used for a couple of years or whatever that has a statistical significance so that we can really evaluate data about dropout rates and so on. So this said, we are doing experiments, of course, because one of the main reasons why you use games in all these processes is to motivate people and to, for example, to prevent that they drop out for example, from long-term rehabilitation, because once the patients are at home, it's getting maybe boring, and they might perceive they're not getting better, while this might even not be true, but they don't know. So they might say, I'm not doing that because anyway it's no use. So one of the things that we do in games is finding a very easy, intuitive way to give a feedback about their process to the user and of course the stakeholders, the family, the loved ones, whoever that is, so that they can see, aha, it's useful to do that because I'm better than I was, I don't know, 1 week ago or whatever. And the other topic about motivation, the other aspect is very often we merge the exercises, let's call it like that, with social aspect, so that, for example, either the family, for example, can either play with them or have a role within the therapy and the games, or they can find other people, maybe even people they don't know who have the same problem, so they don't feel alone. They don't feel what happened to me, but the point is us and how are the others doing. So you can challenge someone, you can see the progress of other people, always within privacy, protection and whatever you can think of. And be motivated, because if the others have some progress, then I might as well do better. So these are things that we do into that direction.
Thank you. Was there another question there?
So it's a question for Ilaria, I think so. So I'm happy to hear that you are investigating about different type of games, not only based on ICT, because I think one of the most issues in elderly people is isolation. And in games, perhaps you can modify this kind of behavior or whatever. And there are some studies that show the people who has big social networking, the outcomes are better than the other. Would you explain a little bit more? Yes. Thank you. I prefer this one to be asked. Yes, it's very important, the cooperation and the collaboration, not to make elderly feel alone. And with some of our games, we try to increase the connection among eldest and youngest. Because, for example, also taking part in the social life and to the institutional life of our country is difficult for someone who doesn't have the access to the information. It's not a lack of abilities, but a lack of tools, of devices, and the ability to use them. So, for example, using games among elderly and young, there could be this intersection and this change and switch of abilities, little abilities. And one of the most important things in games is that sometimes you cannot address games exactly to the person with some disease or problems, but to his relatives. Because sometimes our relatives who has to be trained, because they can provide help and help people feeling better. Their families can improve the quality of life with just simple kind of tasks during the day, and sometimes game can train in this direction. Have I answered?
Okay. If I can say something, because maybe it's a very simple comment, but there is an evidence base of a huge difference when you have telemonitoring without video conferences and telemonitoring with video conference. We experimented, for example, in our region, that when people wait for a video conference, they dress, they must dress, they are prepared, they are happy for that, and it is more evidence that they are more involved also in the other aspects of telemonitoring. And when you have only, yes, some devices without any, or some telemonitoring, like traditional one that is, of course, against isolation, loneliness, there is not this way of preparing, being prepared like a visit and so on. But of course, in a general point of view, the ICT doesn't substitute the home visits of social care, family care, voluntary, and so on.
Good morning. I'm a fitness trainer, and I'm amazed that isn't being touched the argument of physical activity this morning, but I want to make an answer to for the Smart Center Smart Project. Okay. In your experience, you have followed a medical fitness project in the region, European region that you have treated, or not?
Okay. No, not officially, but for example, the Cardiovascular ward that is in the Trieste hospital, that is the main center of management and SmartCare team, it is the base also of the Center for Sports, Medicine, and so on. So we have in parallel some activities for that, but not in cooperation projects.
Okay, thank you.
Another question there.
Thank you. I have a question to Gian Matteo and the SmartCare project, which I like very much. Although it is once again this disease-oriented approach. Therefore, I would like to ask you, what do you expect from your control group versus the project group? Because there it very much depends. You can live, as we also heard from the other presentation, with I think, what is it, coronary heart disease. You have very different people. Some people might live well anyway. The disease as such has nothing to do with their real care needs and with the needs for integrated care, unless you define integrated care as two doctors are talking to each other. So I think here it will very much depend on what indicators will you measure and what do you expect, what differences do you expect between the two groups?
Yeah, thank you, because it's maybe the big challenge that we have, because of course we are aware that when we present the project, we are in the project, there are a focus on telemedicine and on disease because, of course, sometimes it is the main and the more difficult aspect. No, but of course I did not present the part of the evaluation, and there is a quantitative evaluation with all the data that are also automatic generated by the system, but we have a very big phase of qualitative evaluation, and we have the social workers that are already involved in the project that are really person-centered worker, and of course we have, I think maybe also too many questionnaires about qualitative data. The point is that at the beginning, when you enroll people, of course, you have to explain very well the aim of the project, but maybe at the beginning, what we are, of course, I'm speaking about Filippo and Julia, what we are experimenting is, of course, that at the beginning you involve people that you, of course, already know, that have a good attitude on the project, and maybe it is the most difficult to explain for them the exit of the project about a technical aspect. What they really expect is to have a better quality of life, to have, they are really like to be involved in the project. So maybe we are now in the phase where people are enthusiastic to be involved, and maybe we are not still in the phase, we're not yet in the phase where, okay, it's kind of, also the ICT base is a usual care. But I think that the point is how you are going to organize the service. And of course, it's not just to go on people and put in some devices and make people stigmatizing with devices, of course, that, okay, you have a disease, you need technical devices. I think that it is very important to involve people, but to involve also informal carers. And also I think that technology is advanced for being less invasive and less stigmatizing. The main goal of the SmartCare is to have quantitative data that maybe is focused on health aspect and disease, but of course qualitative data and is really, really focused on quality of life. I don't know if I have answered more or less. Okay, but I know this is the challenge. Yeah.
Another question there. Back, please.
Okay, I have a two-part question, one very specific and one more general. So for the one on cardiac care, the tools, the risk tools, is that just because you don't have the data, or you think it's a fundamentally new model that's needed? I mean, I wondered which it was. And then the question for the telemonitoring guys is, do you think that the data that you will collect will be useful or good enough in order to be able to calibrate risk stratification tools? Do you think that actually the data you're going to get would actually link to risk stratification?
Someone to answer this question. So maybe we can start from the category.
If I understood properly, the question concerns concrete projects, SmartCare Project, so it's not my project, but I can perhaps answer a little bit in general approach. All the people who participate in research projects are usually very selected population. There are more healthy, more aware, more wishing to participate, especially when it concerns project, when we have to do something that may be dangerous or may be perceived as something that is not appropriate in a very advanced age. For example, exercise testing. When we do studies with physical activity, cardiology project or geriatric project, then We start usually with many thousands of older people, and we finish with 50 or 60 people who say, okay, I'm able and I wish to participate in this project and to fulfill multiple questionnaires, to do exercise testing, to do dietary screening, and so on and so on. And the second point is that when we talk about all the population, it has been already tackled today, we should always keep in mind the heterogeneity of the population. When we do it with the children, okay, pediatric age is from 0 to 18. When we deal with older people, it's from, let's say, 65 to 105, okay? 40 years life span. And older people are very different. When we would suggest simple games for people that are 70, and those games might be used for people that are 90 with mild cognitive impairment, those 70-year-old older patients can never. We are proposing something that is totally inappropriate. And of course, we should also consider that the burden of several chronic diseases usually increases with age. And when we have 80 or 90 years old patients, we have usually 3 to 5 chronic conditions that coexist together. Our patients usually taking from 5 to 8 drugs on a regular basis, and they are very different in terms of physical approach, health approach to those patients. And what we should also remember that we should have in mind the target is to prevent cognitive and physical decline of our people. But our older patients would always like to do something that makes fun. So when we propose any intervention, it should be interesting for them, not boring, because then the commitment to the project is 1 month, 2 months, and then it's over. When we, for example, use exercise intervention in older population, it is for free, okay? After 1 year, there is only 10% of all the people, at least in the United States, who wants to participate in exercise projects.
Any other questions? There's no. 2 questions. One, maybe you can start with the other one if you don't mind. There's one back there. There's the microphone is there.
I have one question for Lucia and Ilaria. In gamification, when you talk about gamification, I think it's there is a big obstacle, or maybe an obstacle of importance. That is the handle that people have with games and gamification. Especially when you talk about games, in elderly people especially, there is a reject of the concept of games for taking care of issues or diseases. And in my little experience, I saw this kind of behavior. Did you find and how did you handle this kind of behavior or reject for this kind of a problem?
Yeah, that's the problem. It's an interesting topic. The way to address it is to circumnavigate it. Try to make them enjoy a game. In this way, they feel the importance of playing, and so they got you obtain the purpose without being so direct. I don't know. I'm trying to explain myself better.
No, it's the question is because sometimes you can propose the game or to play with another person, but he underestimates and didn't take seriously the things so it didn't make it serious or not play it correctly because it didn't take it seriously.
Yes, this is
Even
the
if-
work
even
of
if
the
it's
designer to make it
enjoyable.
enjoyable.
Yeah, sorry if I may intervene. The point is it's not circumnavigating in my opinion, so it's addressing it, and the way you do it is with co-design that we have heard before. So you include exactly the target group into the design of the game, and that goes also. I made a note when our colleague talked about the risk of having games that are, for example, inappropriate and so on. When you design this kind of games, you include the therapists or the doctors. You have a very careful analysis of what the target group is, so the age, the impairments, and everything that really is fundamental for whatever is your goal, and you design the game from there. So if you involve the elderly people, to answer your question again, into the design of the game, you don't risk that they cannot relate to it or they don't want to do it. And to give a very concrete example about what we have found out recently, is that elderly people like the games to be very closely related to their everyday life. So they gave me a very concrete example. In an Austrian hospital, they were trying for physical movements to do a game shooting at sort of hens or whatever kind of birds. And they said, we are not interested because in our normal life we're not shooting at hens. So when we do our focus groups, we found out, for example, they're interested in games where you have to collect, always for physical movement, glasses or whatever, and put them back into drawers. So you have to do these movements to retrain your upper body. Or you go to a real supermarket in a virtual reality experiment and have to navigate through the corridors and do your shopping according to your shopping list if you want to combine exercises for mild cognitive impairment together with directions and movement and so on. So I think that then the risk is not there anymore.
Yeah, the user-centered design is our main approach. Maybe I took it as something basic and I did not say it. But we start from considering the user, his or her needs, and so on. And the cooperative, the co-design is an important part of our methodology, of course. Sometimes it happens that you have games with particularly difficult topics and issues, and you have to choose what kind of approach you want to use, and it depends on the target. You cannot say it in advance. It depends from the specific situation. But what Lucia explained is, I totally agree with it. Yeah.
Can I just add a very last note on that? And at the end of all this process, if it's the case that the person doesn't want to use it, well, he or she should still have the choice to say no. I opt out, and so at the end we should not force anybody to use the tool just because we know it's good for their but to try to respect also what is the last voice.
Maybe if I can add a last note about this games topic, because I think there was an implication before in one of the questions that having games that are technology-based means sort of social exclusion, or in other words, if you have that, you play on your own. But please remember that, for example, in the WellB project that was mentioned before, we have social aspects and exer games, so physical exercises based on games, and we combine these things to push the people to get out of their homes, meet physically with their mates or whatever other people in the program, do some things together. The exercise might be we do together a walk in the park, and the game is based on that, so you can use that exactly for the opposite objective, so to make them really socialize, and then in some sort of smart way report back, add a picture or whatever, so that you can check that they did it, if they wanted, as you very correctly said. But technology doesn't mean only being on one's own and having some sort of PC, tablet, or whatever in your hands.
Just to puntualize, games are a free activity, a voluntary activity. If you force someone to play, he's not playing anymore. That's a meaningful point. I mean, you cannot force someone to play. That's.
There was a question in front here, second line maybe. Can you have a microphone? Here.
The organizers today have managed to bring together at the same room very different perspectives, and it's not a usual case. So I would like to ask your comments about the common place between among these perspectives. To be more specific, I would like to ask Dr. Garuti and Dr. Kostka if they are sharing the same optimism feelings like Dr. Apuzzo described. Because you exactly were very, very conservative according to your experience so far.
My experience is very good on telemedicine because, excuse me, my experience is very good with telemedicine because I reduce healthcare resources. But in the time, the patient tend to lost the compliance to telemedicine, and we need more education for this patient to perform better this system.
Are you sharing the same optimism?
Yes, so 50-50.
I just connect. I agree. I'm sharing moderately this optimism for the future because I'm a geriatrician, so I see everyday people who are 80, 90 years and older, and those people usually are not able to use this modern technology. So, but I can imagine that after 10 or 20 years, we can educate our older population to be more adapted to use these technologies.
There's some comments on this question.
So I would like to say that it's important to train older persons when they need, but I think it's even more important that we are talking about prevention also, to start also from the younger generations to start getting acquainted with those tools and to use them in an everyday basis. So when the need really comes, in a sense, we are already a bit prepared. It's not something new that happens in our life and we need to deal with it or be forced because of the need.
Yeah. If I can add, I think that this is the point, that a generation that is used to technology is coming to be older. And the point is that maybe people will be more used to the organization of healthcare and social care. This is the point that, of course, now is a challenge because we have now an older population and a generation that is not used, is not educated, and they can't use, in some cases, the ICT and ICT. But, of course, there are arriving in a generation, in a very few time, that is used. That is, maybe they will have really a challenge in having what they are expecting. Because, the organization of health and social care is not prepared for ICT use in some cases, of course. That's why I'm optimistic, because we will be forced to use that.
I think if I may add something, I think we can see that, I'm not an expert on gamification, but I think this is a very relevant point. We are seeing that in our children or in our young generation. How many of us actually were playing with iPad at 5, 6, or 7 years old? Not actually, no, but because the technology was not there. It's just a matter of getting used to something which was part of our life for a long time. And this is what is going to happen 10 years from now. And I think all this discussion we're having today, it's having, importance in a dedicated study and in a restricted areas and population. But in 10 years from now, this could be really a broad approach. for primary prevention and also for secondary prevention and in the tertiary prevention step. So it's a matter of continue discussing and providing new tools for technology. There was another question there.
Yes, I would also like to come back to the gamification, and I would like to ask if there are also if the intercultural aspect in our increasing diverse societies is somewhat a topic in the development of the games, if there are cultural aspects. And the other question would be, how does the gender aspect be mirrored in the games? Because my experience in the Space Project was that the ladies reacted in a quite different way to what we did to the gentlemen.
Yeah, well, if I may answer this question, I'll start from the end. Ladies, can I say that, are often much smarter, so they react better. Louder, ladies are smarter. No, really, I mean, one would expect the opposite, because when we talk about education of scientific subjects and so on, then we have a lower rate of females and so on. But really, I mean, ladies are much more, I don't know, maybe open to experiments. So the gender issue in case is, well, turned around for once. So normally we don't have any problem with that. And if you are talking about the gender issue within the game, very often you don't even see yourself in the game. So either you have an avatar and then it's not really relevant, or you live the game or the virtual environment in the first person, so you see the environment changing as if you were moving in it, so the gender aspect doesn't really, it's not really relevant. Yeah, and then the cultural aspect, that's a very interesting question, of course, as well. Well, we have to say that northern countries are normally more used to technology, so technology pervasiveness is higher. So for them to use these things is more normal, and I think they're more, I mean, it's not nice to say, but a bit more open-minded towards the concept of game, although that's changing. I'm talking especially, if I talk about southern countries, especially of Italy, because that's where I'm based, it's changing quite quickly. So we are seeing, because we don't have to think only of the patients, but especially of doctors and therapists, because that's the first person you're talking to. I mean, you don't produce, as I said, you don't produce a game and give it to the people. You have to go through the doctors and therapists, also because they need to be scientifically sound and they need to reach their objective. And until, I mean, we have this company since nearly 11 years. 10, 11 years ago, when I talked to people, they were looking at me as if I was just flying down from the moon. And now they want to try it. So it's changing quickly, I think. So the gap is being reduced.
Thank you.
Someone else want to add something on this topic? Not about the gender issue, because we have heard enough, I think. You know. Joking, of course.
They're very afraid now.
We are afraid about these things.
Now everyone knows how bad I am.
Okay.
Perhaps just a very short comment that we should discern now, at least in Poland, in other countries, I think too, between urban and rural population, because in big cities there's usually no problem with using modern technologies. When we go to the small villages, the problems are really very huge.
Yeah, that's a very good point. Also because when we use the games, we want data to flow, for example, to the medical center. So issues of connectivity are very important. So thank you for pointing that out.
Sorry? Any other question from the...
Okay, I use my voice, it's not a problem.
Yeah, please.
My diaphragm is good. I have an answer for Ilenia, and the platform is useful for all people, in your opinion.
Yes, of course. And it's great to see how, well, in our case, of course, our members are getting more and more involved into the issues that seem also very far from them. We are working with also local associations of older people, older into brackets because 50 plus, it's not old. But and it's great to see how they get mobilized and how we can really involve them into a lot of practices. There is interest in research, there is interest in learning more, there is interest in getting involved, and the outcomes also are quite positive, also because they see that the lessons learned are not just kept in a bookshelf, but they are shared, and we try to make them be heard at a higher stage, where possibly then the legislation can evolve in an age-friendly sense, in an age-friendly direction, let's say.
Any other question? If not, I have to thank all the speakers of this morning, and I want to personally thank the organizers for putting this table together. As was said, it's a unique opportunity of sharing of medical experience, high-tech experience, and project management. So that's very important. And so thanks to Democenter for organizing all this. And in the program it was foreseen a lunch, and however after hearing the presentation of today, this morning, there will be a race. It will be 5 kilometers race around Mirandola. So no lunch today, to have some exercise. So please enjoy it.
Meridiana, siete pregati di riprendere posto. Ladies and gentlemen, we will start the afternoon session now, so please take your seats. Thank you.
Well, good afternoon. Buon pomeriggio. I do know that some of the participants had to leave because of some flight departure time, but I invite anyone who wants to endure to the last to be here. So as you know, we organized this meeting also in order to be able to let's network together. And this afternoon session, this afternoon roundtable is going to discuss exactly this point. So it will be, I just make a draft of what you're going to endure tonight. It is, first of all, Professor Ferrari, who is Vice Rector, Vice Chancellor, no, Vice Rector at our university. Then Dr. Bezzani, who is a representative of EIP. Then myself, who will be summarizing what we did yesterday. Professor Dominici is summarizing what we did this morning. And then Dr. Costantino, who is going to talk about networking, European networking, in the next calls. And finally, Giuliano Fiori discussing what we can offer as Technopole, local Technopole, and what we can do to favor these networking systems. So now I invite Professor Ferrari to give an overview of what the University of Modena and Reggio, who is co-hosting here the meeting, right? And so, please.
Thanks so much. Well, good afternoon to everybody. I want to thank Aldo, Massimo, Enzo for inviting me here. I am Vice Chancellor of the University of Modena and Reggio Emilia. And Modena and Reggio Emilia are cities near each other. It's the first example of network university in Italy. So that's a good example of networking. So the university is open to opportunities to collaborate, okay, with other countries for several aspects. We need to exchange students, and this is a point, but is well done from the Erasmus organization. and then to exchange postdoctoral, postdoc in different fields, and then professor, and then to make partnership with other universities to do this, for these initiatives. And this is the point. And then we are interested to create opportunities in other countries. And in fact, we are in contact, and the next week I will be in China, and then in Vietnam, and then in India, and then in Sweden, and then in England, just to try to discuss with several universities and to discuss of this point of international exchanges between our university and other universities. And that's a good point, but it is not for this keyword that is internationalization. Is not only made by university, but everybody is doing this, no? Industries, no? And many other organizations. So the idea is to join together in these opportunities in industries, university, and to have an impact on other countries. And the industries are very important, and for this reason, Democenter is important for us to create this contact with the industries, because we can start with the student stages abroad. We have several industries that have the main activity in Italy, but they dislocate in other countries. And this is a good start because we have the opportunity to exchange in the two ways. Italian students can go abroad for several months, and vice versa, from India in Italy, from China in Italy, from Vietnam in Italy, and so on. And this is the first point to exchange and to create mobility on students for professional purposes, okay, to make stages abroad. And then the other opportunity is simultaneously to contact university for the formation and to establish contact and opportunities for courses, formation, and this for the students to create a double title or other type of collaboration in this aspect. And so we are pretty active in this field, and this is a necessity because I believe that the university has to open abroad and to create for our young people these opportunities. And in fact, from 2010, more than 100,000 people, the young people, is going abroad from Italy. And this is a really impressive data, no? And they are going to work in Spain, in Germany, in France, and so on. And we are not able to maintain these people in Italy, to create opportunity in Italy for job opportunities. So we have to work a lot on this field to create really opportunity for young people that are in the different fields. And then another possibility is to contact and to establish contact with other universities is to call at the university for the keyword that is excellence in research. We have to promote our best research abroad. And the research that is characterizing the University of Modena and Reggio Emilia. In Emilia-Romagna we have 5 universities. So we have to find really what is characterizing our activity. And this is possible because we have mechanical engineering with all the fields of mechanical industry, automobile industries like Ferrari, Maserati, Lamborghini, and so on. So this is called a very good brand for other countries. And then agri-food is another characteristic that we can promote abroad. And then biotechnology, and then medicine, and then nanotechnology, and so on. So we have several characterization. I don't know if these research are excellent because the word excellence is difficult to define, okay? But they are really good and characterize our university. So we can promote this activity, and we try to make exchange with other university at the PhD level, PhD program. to exchange PhD and to possibly create the international PhD or European PhD. We don't have one international PhD in Modena, so that is a good point. Okay, and then the last proposal is to create MOOCs. MOOCs are online courses. There's so many MOOCs in the world, from Harvard, Cambridge, and many other good universities. But if you propose what is characterizing our university, maybe MOOCs have a sense, no? For the promotion abroad. I mean, a lot of people can follow these courses online, and we can promote the image of our university. So I think that I can conclude that I hope that these opportunities of establish contact with other countries, with other universities, can be successful for our university. And I thank again Aldo, Massimo, and Democenter for inviting me and to have the opportunity. And it's clear that we have to work together. We have to have synergism in these initiatives, because in industries and university have to proceed together, no, in other countries to establish. And then I don't want to speak about Horizon 2020 because we have the expert, and so I leave the word to the expert. Thanks so much.
Thank you, Sergio. So now is the turn of Giorgio Bersani as representative of EIP Italy.
Good morning to all. If I have the first slide, please. Thank you. You have already known what about IEP on AHA from Dr. Pavlishkova yesterday. I wish to show you what our region, Emilia-Romagna, is going to do. In Italy, only 5 regions have given their commitment to this European Commission project. And you see Emilia-Romagna, Piedmont, Liguria, Campania, and Puglia. What B3 Integrated Care Action Group do? As you see, there are 9 action areas, distinct action areas. You can read the purpose of every one of each of them. And Regione Emilia-Romagna region, by means of the Social and Health Agency, gave its commitment to this project, choosing only 5 of the action groups, as you can see. Action Group 1 is led by the YOR hospital, in particular by Dr. Luca San Giorgi. Action Group 2, the Bologna University, Professor Lorenzo Chiari. Action Group 3, again, Bologna University, Professoressa Laura Cazzà. Action Group B3, 7, capacity building by myself. And Action Group C2, Dottoressa Teresa Gallelli, on behalf of CUP 2000 Bologna. who are our collaborators on B3 Action Group Integrated Care? As you can see, local health authorities of Reggio Emilia, Modena, Rimini, Ferrara, Reggio Emilia Hospital, Ferrara Hospital, Open Evidence, Lodz University, Democenter-Sipe Foundation, our daily host, CUP 2000, and Italian Telemedicine and Health Society, Italian National Research Council, Italian National Agency for New Technologies, Energy and Sustainable Economic Development. This for tell to everybody operating, working in Italy and in our region, to give the opportunity to join our working group in this field, because we have to collect the good practices in social and health fields in order to sharing these informations to all politicians, administrators of our local sites, to ameliorate, to let grow, and to modify the capability and efficacy of social and health assistance from now to the future. Thank you.
So now it is again my turn, and my ambition now is really to summarize very quickly what we did yesterday, pinpointing what I thought was the most important point, again in order to favor these networking possibilities. Obviously, Democenter will take charge of keeping in touch after the end of the meeting and see with the various groups if and when and how we could go forward for further networking and collaboration. So let me summarize very quickly. And what I would say, we have 3 sessions, actually one big session divided in 2, and which were highly integrated really. In some ways, sometimes the difference being assigned to the first or the second was only a matter of just saying, okay, for sake of saying, you come first and you come afterward. But anyway, there's really highly integration things. What we learn is this. First of all, okay, the age increases in Europe. And this, we understand it very well. The second point, the polymorbidity. The polymorbidity points, I think this is the most basic point which we all have to face with. And I think really the society has to brace this situation. Aging and diseases is definitely connected. We have seen the increase. We have seen in some instances, only 50 years ago or 30 years ago, the morbidity was completely different. Up to 1960, if I remember well the slides, only a small percentage of population had 4 or 5 diseases at the same time, while in the current situation, 30% of population, aging population, had comorbidity of 3, 4, or 5 different diseases. So the need of increased care and here's the possible answer. So one of the major issues, and I put it first, perhaps it's my bias, was about, say, call it the expenses side. And so we have some business associates which really discuss the point of view, and I remember Marta Rivera, who was discussing from the business, what they call it the business school, really what is going on and what is going to happen. I mean, But obviously it was also Dr. Venezianos, sorry, misspelling your name, who was underlining what is the possibility. Perhaps the crisis might be a moment in which we can reassess our goals, and perhaps also we can save money, giving better care. And obviously ICT is entering very important, it's going to play a very important role. And so I would just underline what remains in my mind about new type of application. And I appreciate very much what Andrea Pavlikova is doing in Scotland. As much as Drago Rudel in Slovenia is trying to do. So application, ICT application is something which in a future program must definitely be here. Right? So must definitely play a very important role. And the other issue which should be addressed if you really think to make a European application is the fact that all these applications, all this ICT implementation are usually not standardized. And these are the major problems and the other major points which came out quite well. And obviously I thanks Bridget, I don't see her here. Okay, leading down there. Because she really gave an excellent and very passionate talk about what could be, the implementation, but standardization possibility, interoperabilities of systems and so on. Because really, the local situation, even though might be solved brilliantly for that particular case, if it is not spread, it doesn't make any sense on the long run. And this also was the worry, if you want, of Kai Laxonry, which is, I think, is left. Also dealing with European worrying about standardization and what is the project the European Union might bring forward. And I think many of you were hit by the talk of Qualcomm Thomas Olsen, which really is addressing a really important point. The platform and the substrate, which should be really common. It is strictly connected to the standardization point, but obviously if we could have a common operative system, call it like this, as we used to call it in the past, for the computer, which speak the same language, it would be very useful. Obviously, the company Qualcomm is going to offer something, but obviously this is something we have to think very carefully. And so, again, in an application to the CHP 25, for instance, which many of you pinpointed as the most important next call, is, in my opinion, has to be addressed. So someone has to take into account that we should use a common interoperative system. And finally, domotics, but again, this is really part of the big ICT and application. And so let me just thanks Anne Blakelock, who was give the final talk about possibilities. Where also domotic is going to intervene into a very common day life of age people, like the sheets or like the shirt they wear and so on. So very interesting and nice talk. I think this is my summary. And again, what I believe is this: distilled thought is this. In an application, European application, I believe that most, if not all of these points, has to join into a nice network and collaborate. But now I leave the work to Massimo Dominici, which is giving his view on this morning.
So I have the lucky because all of you were assisting to this morning presentation, so you have fresh memory of what you've seen. I'm just trying to summarize the major topic and some of my understanding in this area. And I'm coming from a medical point of view and from a researcher point of view, and so just trying to share some of my thoughts regarding this morning speech. So this morning we were facing the prevention. We saw, as I was stating this morning, we saw different type of prevention. The all three levels of preventions were presented. They were essentially explained in different ways, but all of them were targeting the major aging pathologies, cardiovascular, but also lung diseases, which are a big part of cause of death for elderly. And so, for primary prevention, we saw how it's important to create a network. This was essentially, presented by Dr. Caimmi. To reduce, how can we reduce the risk factor for pulmonary diseases? In that case, the model that they present, it's really, to understand when the risk factor is increasing. In that case, is asthma, so it's related to environmental factor which would generate the problem. And the detection was proposed by, either the single patient will alert a network of individuals that that specific pollution is going up. I think it's a very good approach, but I presume that this should be done more at the governmental point of view rather than to a single individual. Certainly the single individual can do his part, but there should be like some sort of alert system that will alert that specific patient category that this might take place. And this is an example of telemedicine related to the reduction of the risk factor. Second point was related to the secondary prevention, which means early detection of diseases. And we observed essentially the cardiovascular fields and the SmartCare Project, which one is more linked to a medical need. The second one is a growth project, which I see it's targeting the needs of these patients. So early detection in this case, is really again related to technology, to medical devices which are placed in the houses of patients or are placed in the house of elderly that can simply measure the basic parameters like blood pressure and to identify early sign of hypertension, for instance, of early signs of diseases. I would say that this is already done because you go in any type of pharmacy here in Italy or in every country, you can do that. You can measure your blood pressure. In that case, it's in your house, so it might be easier to do. It might be, let's say, more complex to accomplish, but I think is something that would certainly be of help. And I think we need more technology. We need more technology to address and to identify early signs of diseases. I was impressed about the concept that is also part of my clinical research activity. I think Dr. Kostka was mentioning about the inflammation. The inflammation is a common event in chronic diseases, either in the cardiovascular, in the lung, but also in cancer. And so identifying determinants of inflammation may be a common topic for all these chronic diseases. The CRP is the basic parameters that can be measured in every single lab in the world. So if we want to identify, biomarker and marker of diseases, of early diseases, I think that's a great opportunity. Identifying common biomarkers for several diseases, and here we are talking about the major one, I think might be something which we should consider. This is done with the glucose level for diabetic patients, but if we are able to identify one or two markers of inflammation, that's maybe something that can certainly facilitate early detection these diseases. Then finally, it was mentioned about the prevention of complication in already sick patients. So third level of prevention, and lung diseases in this case. I think it's a very good example for lung diseases where you have few parameters to monitor, the saturation of oxygen or other basic event that in 2014 we can actually measure. And all this information can be sent to the hospital. And if there is like a beginning of alert signal, then this physician can go to the house of the patient, avoiding a last-minute emergency room admittance, which certainly be a problem for the patient, but also a problem and a cost for the society. So I'm seeing how technology can facilitate all these aspects into the prevention field. And then finally, we've heard about very interesting, at least to me, games which facilitate social integration, but also activity and brain training and constant brain stimulation for elderly, and to provide them a more inclusive sense of being part of the society. Loneliness in this type of patient is a big issue, is a big problem. And so the gaming might be something which could push those type of elderly people into a more active world, and being active and independent, like I was saying this morning, is certainly very important for this patient. So I think I cover all the topic of this morning and sharing some of my thoughts.
Thanks, Massimo. And my final comment is, I think the networking possibilities are all here. The Democenter has taken the task of making these meetings, organizing these meetings, and now I think I give the word to Costantino Raspi, because we also provided our expert in EU code, and obviously I know that many of you, most of you actually, are already quite expert into European code, but I'd like to invite our own, say, European provider, is it the definition of your word? to illustrate what is going on and what are the next challenges.
Okay, good morning to everybody. Sorry for my terrible English. My name is Costantino Raspi. Thanks to Aldo, in particular to Enzo, and to Laura for inviting me to talk this morning. And I am so young, but I am a long experience in the European project. And I want to start as I will finish in a few words. The message of my speech is that now in Italy you can have a new partner for your European project. Now Democenter is able to be involved and to promote European project. We have developed a very strong European group into Democenter for submitting, preparing and collaborating in the European project. And in particular, as Juliana will detail you in very specific technical words, Democenter is the owner, the manager of a very ambitious technopolo with many skills, many tools in order to be a great partner in the biomedical European project. Then I think everybody knows something about Horizon 2020. It's the new name of European program. I started with program 4. They followed the name, the number until the 7. At the date they changed the name. It's Horizon, but the content is the same. Which is the three main particularity of the Horizon 2020. One is the coherence between what the EC wants with the idea. I have listened from Aldo and from Massimo many interesting ideas from your speeches in these 2 brilliant 2 days. The great part of our work in Democenter is to try to transform
brilliant idea in European project. I worked also as an evaluator in Brussels, and I know that it is one of the objectives of the Brussels is to receive not a great idea at stop, but also great idea presenting at a great project. How is the definition of a great European project? It is a project in Horizon 2020 with concrete and measurable objectives, in particular for the increasing of competitiveness and market for SMEs. Then the two great keywords of Horizon 2020 are SMEs. Now the ideas has not to be great university publication or great idea just for a book. Now the European Commission, on the basis of the European crisis, wants projects able to increase really the market of the SMEs. The SMEs has to be the main proposer, the coordinator. If you have a partnership of 10 partners, it is better if 7 partners are SMEs. It is important to have the centralization of the SMEs in your project, to have as objective something useful for the market of the SMEs. The second then is completely related to the first main point of Horizon, is to have something concrete and measurable, to have some objective, very real, to propose to the market. The born of the Horizon was from the last 7 work program, where after a questionnaire, after a survey made on from the EC about the results of the project, the result was nothing real in the market. No invoices from the result of the project. Now the EC transformed the concept, the basis of the funding of for the European partners. Now they want help really SMEs in transforming the result of the project in something useful for the market of the SMEs in the biomedical sector we are talking, but also in all sectors. Then Democenter is from many years is in strict contact with many, in particular biomedical SMEs of this specific district of Mirandola. Then Democenter is able to involve European partner in European project useful for SMEs. Which are and in particular Democenter, we have already submitted 12 projects in Horizon. Horizon is a labyrinth, it's complicated, but not for Democenter. We are able to teach the way for submitting, we hope, winner project. In particular, for the next year, we have individuated 3, almost 4. The last one is in red, is just because Laura loves it. Is the third, the 3 are very related to the.
We cannot see.
Can you put the slide on, please?
I'm sorry. I can see here, but you cannot see.
It's better to see Constantino than the slide.
Yes. Okay, I can talk about the free code. Qua c'è. C'è il problema del della regia che deve fare quella cosa. La regia ha fatto Okay. We are talking about ICT, but we have still problem. Okay, then we have 3 calls in April. One is PHC 21, 25, and 27. which is very important in Horizon, is the perfect coherence between what is the topic of the call and the idea of your project. Then it is mandatory to be very, very coherent with what is detailed in the characteristic of the call. In particular, you can see that it is important for Horizon to have defined a free call about the link between ICT technology and health sector. In particular, the first one, the 21, is related to the use of ICT system for helping the aging phase. In the when it is open to submit any type of idea that can detect early the problem that people can have from a mental and in the life of the aging phase of the people. Is more open, there are not strict details for the first topic. In particular, it is underlined from they see the multi-acting approach. We have to use the ICT system and to analyze the use of the ICT system also from the social point of view, the gender point of view, in order to adapt, to tailor the ICT system for the specific need of the people when is in the aging phase. In the second part is the second call is more related to integrated care. All the three calls are related to the use of ICT. They are very similar, but we can find in the rows of the call small differences. In the first call is more related to the help from an external point of view, a technical expert to help the people to use the ICT system. In the second call is more related to teach the people to use the ICT system in independent way, as in the third call, where is defined self-management, which is the main objective of Brussels. To reduce the cost of the biomedical sector, to reduce in particular the cost of the hospitalization, and then to help all the people to have a self-management of ICT system, in order to have a portable, to have an easy system to use in the house, not to go to run always to the hospital. Then the first call is related about the possibility to have technical expert to use people to use ICT help. In the second, in the third is more related to teach the people to use ICT system from a self-management point of view. And the budget related to these three topics is not so high, it's just around 4 million euro. The red one is the 33 call PAG is not strictly related to the aging people, is more open to all the situation related to toxicological problem. It's a call in order to find a new toxicological solution in the biomedical sector. But we have put this because it's a bigger call, is a bigger budget. The budget is around 10 million euro, and then it is possible to involve many partners of many countries, of many possible technical feasibility. Then this is the call of April, but as you know, in Horizon 2020 they will change, individuate the call each 2 years. This is the last call of the work program of 2014-2015. We are waiting for the calls of 2016-2017. These are research and innovation calls, when the funding is 100% to be distributed by all the partners. And we hope that the Democenter can be one of the partners. And then, as I start, I can conclude. Then, about ICT, Democenter, Massimo Garuti here is one of the main genius of ICT in Italy. Democenter is able to promote new projects, to help you in collaborate in the submission of winner project, we hope. How? In particular with our experience, and now in particular with the new tool that we have, which is the Tecnopolo, that Giuliana is going to illustrate to you after my last greeting. Thank you. Bye.
Okay, I know there is a slide. Now I would like to give you some information about the Democenter, mainly from the point of view of industry, let's say from the organization that is the support to transform, as we said, ideas to projects, possibly founded projects, and after this to products to be used on patients. So let's say the eye is not here, it's usually. Okay, fine. But the slide is only one, so and the Democenter is a foundation. So and the Democenter is organized in 3 divisions. One is a mechanical division, the other one is ICT division, and the last one is the biomedical division. The 3 divisions are interconnected, of course, and we talk along in these days about ICT. So you see that the cooperation with the ICT division and the biomedical division, I think, is increasing a lot. In the biomedical division, and mainly after the earthquake, it was possible to establish this technopole, this in particular more than the technopole, this Science and Technology Park for Medicine here in Mirandola. The founder are coming from the region Emilia-Romagna that gave us Democenter funding support to realize in the area a technopole with the 3 research laboratories, and also gave the possibility to found here a post-diploma institute for, let's say, postgraduate students, and also incubation of ideas. The Technopole has 3 laboratories. One is a cell biology laboratory, another one is biocompatibility toxicological laboratory, and the third one is a sensor laboratory. These laboratories are, let's say, mainly worked directly by university professors, and they will work on projects that are coming from the industry. So you see that, let's say, there is a real established, well-established organization that can really make possible what we said before, starting from an idea, a concept, go to a founded project possibly, because we know that to develop a product we need a fund, of course, and after this to have a product to be used on patients. The Technopole is not working alone, but we are establishing and already established a lot of cooperation with university, with hospital and healthcare providers, and also with the biomedical enterprise, so with the industries. In this, let's say, so as I said, well-organized structure, which is the base of the network. So let's say today what we would like to show you is the possibility to cooperate together on all the matters that were presented during the last 2 days.
Thank you, Giuliana. When we started yesterday morning, I was saying, okay, Latin time, and I was trying to impose some kind of order, and I noticed that I was able to impose the order up to the last minute. We say we finish 3:15. It takes a few more minutes to come to the 15th, but so I express satisfaction. So we were able to do order and good meeting. I just summarize again. I mean, here you had the possibility to meet, and I know that already quite a few of you already have meetings, interpersonal meetings, and so on. We would be very happy if this meeting is going to bring you some further collaboration, but we were even more happy if Technopol and I mean STPM, the scientific technology part of Mirandola, is taken into this game, in the sense that we can play this game very well. You have understood that we can give substantial support in the application, and obviously this doesn't mean that we want in any case the direction or whatever. We just want to take part in meetings and we want to give contribution. On the other side, Technopol of Modena can give another big opportunity, which is giving that very important networking with SME. SME, perhaps everyone understands, but it's small and medium enterprise, right? So just to make it certain for everyone. And so, and this is what we are specialized in. We have direct contact with hundreds of small and medium enterprises, local and European, and we really can head into networking and fulfilling what the European Union like to do with this new project. New, right? Okay, this is already 1 year ago. But anyway, it's going to be for the next 5 years still here. So, if anyone wants to say anything, what we expect though is this. We will keep track of you. We will send you invitation, but obviously we are also ready to, if you want to contact us. So there will be a two-way direction. Okay? If you think that you have some ideas and if you want us to co-work and to develop and help developing, please contact us without any problems. You email, you find our email, telephone numbers, and whatever. You know me, you know Laura, you know everyone now, right? And so it will be easy to contact. And so let's see if we are able to establish this two-way connection. I think this is my final word. It's 3:10, so 5 minutes in advance. And thank you very much for being here.